I didn't introduce myself. My name is Luc de Witte, and together with Stephen Potter, who did the majority of the work, we have tried to coordinate this part of the pitch-in program about Internet of Things in health and well-being. The agenda for this afternoon is a short overview of the theme, what is this about and what have we done in the past years. After this short welcome, I will give that overview in about 10 minutes. Then we will have an overview of the projects, more detailed projects that were done, that will be done by Stephen. And then we have 4 very typical and very interesting, in my opinion, examples of the projects. And together these projects will show what can be done, what the potential is of Internet of Things, but also the barriers and the challenges. So we hope that all together will give you a good impression of what we have done and more importantly, what the potential is of Internet of Things applications in healthcare and for health and well-being, and also the challenges. At the end, we will try to summarize that very briefly, and there is time for discussions and some question and answers. Everything should be finished at 3:30, and I promise you we will keep to that deadline. A short overview of the Pitch-In program. Pitch-In was a really large project involving the University of Sheffield, Cambridge, Newcastle and Oxford, plus a number of non-university partners. And it ran for 3 years. We are almost at the end, not really, but almost at the end. And the idea was to promote the Internet of Things via collaborations between these organizations. The purpose of the whole program was to investigate barriers to collaboration and to the uptake in the use of Internet of Things applications, and to learn together. The idea is that Internet of Things is a very, everyone speaks about it. There are many conferences about it. It's a technology that is rapidly developing, and there are many applications possible. But at the same time, it's not so easy. It has not really been taken up a lot because there are quite a lot of challenges. The idea of this program was to learn what are the real barriers, what are the opportunities, what are the challenges, and how can we, by working together as higher education institutions and industrial partners and healthcare partners, how can we together learn and find the best way of harnessing the potential? And we did that across 4 very different fields: energy systems, smart cities, and manufacturing were major application fields. But in this strand we talk about today, we focused on applications in health and well-being. Why is that interesting? Because, as I said, it's a fast developing field with many possible applications, but also a very complex field. The technology is not so easy, but the healthcare system is also not so easy. It's a very complex system with many regulatory issues, many stakeholders involved, unclear business models, and many more barriers. So it's not so easy to come up with a specific application with a solid business case and then implement it. So we tried to understand these barriers and try to overcome them. So all these we have performed a number of smaller projects, so-called mini projects, and as I said, some will be demonstrated later. And these all focused on specific barriers, and we try to find solutions. Well, today we will give you an impression of what we have found and experienced. Stephen, can you? It doesn't seem to respond. Can you? Yes, thanks. Well, what is the Internet of Things? It's easy to say, and you read a lot about it, but it is not easy to define what it actually is. In principle, it is not very difficult. It's the idea of monitoring, measuring things, and sharing data, collecting data, analyze the data, and somehow control things to do with the data. Typical applications are in production lines and for example, automatic ways to monitor and measure pollution levels. You have sensors across the city, and they give information about pollution levels, and that can be fed back into kinds of advices or even actions to stop traffic, to slow traffic down, whatever. All you can think of a lot of applications, and the similarity is you have data, you need to interpret these data, you have to do something on the basis of the interpretation of the data, and that is now possible online, remotely, without a lot of personal intervention necessary, because we have artificial intelligence, we have a lot of data techniques, and that so it's a rapidly developing field, but it's a conglomerate of different technologies that together enable these kind of applications. That sounds simple, but the possibilities to measure are almost endless. You can measure almost anything. What is relevant to measure, what is meaningful, and what conclusions can be drawn from that in a meaningful way. It's very easy to measure everything in someone's home, for example, but when is something a problem? When does it need an intervention? When does it require action? And if it requires action, what kind of action then, and who should do it? Many issues. May I have the next slide? The idea of this is in principle not new. The first applications are already from the 1990s. As even longer ago, we had the first applications of telehealth and telecare. But recently, it has become much more powerful, much easier because of developments in hardware. Our computers are smaller, cheaper, faster, more efficient. There are many more possibilities to measure and different kinds of sensors. We're using less energy. Connectivity in our digital networks has increased dramatically. There are much more powerful ways to analyze data. There is artificial intelligence that helps us in interpreting data. And in society, we are much more used to technology. The technology is almost everywhere in our lives, so it is more easily accepted. So these developments, so-called emerging technology areas, really push this field forward and dramatically improve the possibilities. So that's why it's interesting to look at the applications. And in many fields, in manufacturing, for example, it is nothing, it's already implemented to quite a high extent. In healthcare, it is relatively new. Although, if you give me the next slide, everyone knows this example. This is a typical example of what IoT is. Many of you have a Fitbit or similar activity measurement tool, wristband, and that collects data about what you do. It gives you feedback to tell you how many steps you've have taken on a day. It compares it automatically with what you've done last year and last week, and it calculates averages and can give you feedback and advice even. Do more, do such. So this is typical basic Internet of Things applications. Data are stored, it's somewhere on a server. But the same example also shows what many of the issues are. May I have the next slide? because this application raises many questions. For example, about data. Is my data secure? Is my data private? Who stores what? Who knows what about me? What will they do with my data? Who owns it? Really, a lot of questions relating to privacy and security. Is the data secure? Is it can it be hacked? Is it yeah? Who guarantees? What guarantees do I have about that? Compatibility issues. Does it work with my smartphone? Can I use the interfaces? Can I have access to the data? Because in many applications, for example, in Fitbit, you can't really access your data. You only get the interpretation. Is it comfortable? Is it accurate? Is it reliable? Well, many questions there. My wife and I, we like walking a lot, and we always measure how many steps we did. She always wins, while we walk exactly the same distance. So there is a problem with the sensors. Is the analysis accurate, etc. And then, more important, if you think about applications in healthcare, is it really meaningful? Does it improve my health and well-being? Is it beneficial? Does it have added value? How often to use it? When to use it, etc. And of course, that all comes together in the question: is it cost effective? Is it worth the money? These are a lot of questions raised by a very simple application that we are all familiar with. If you think about more complex systems, you will easily see that the questions will also be more complex. May I have the next? I just talked about one application. We did a large survey of the literature looking for possible applications that have been described. And we found a whole range of very different possible applications. We summarized them into 3 main categories shown here. A lot of it is concentrated around personalized care. The Fitbit example could fit in there. There is a lot of applications around public health applications, environmental monitoring, epidemiology, so measuring spreading of disease in community healthcare. And you talk really about dozens of examples. And smart logistics, more smart management of a hospital building or a healthcare facility, information management, measuring of monitoring resources, for example, in a hospital or in a care setting, other care setting, to see where devices are, if everything is still operating okay. These kind of examples. And looking at this, it's really overwhelming. I think we had a list at some point of over 100 examples described in the literature. May I have the next? Stephen, yeah, there, thanks. If you look at this, as I said, there is a lot. And some of them are really successful. These activity trackers or lifestyle monitoring devices, they're quite successful. There are some good examples of monitoring systems, more complex in home. People to monitor people with frailty or early dementia. Smart home control systems, of course, a famous, well-known field. And as I said, resource monitoring systems. But there is just very, very limited insight into what is really meaningful, what is clinically effective, what is cost effective. It's hard to integrate these systems into the formal care system. It's very often isolated and limited to a certain project, and almost, very rarely becomes part of the way we work. The business models are unclear and not very strong. And of course, many questions around the benefits. That's a bit of a feeling of what you get if you look at what's happening in the applications. May I go to the next? So it's obvious that it is not very easy. It's technically complex. It is complex in the care setting. There are many questions around security, privacy, verification, validation, etc. All these things I mentioned. And a strange conclusion maybe, but it seems very easy to build a bad IoT system. And it seems to be very difficult to do it right. But it's also very clear that if you look at these examples, that there is a huge potential. There's a really a huge potential in many areas that could improve people's lives and could improve the efficiency and quality of our health and social care systems. So that's why our study really reinforces this idea that there's a lot of potential. If you look at the challenges, we looked at the literature, but we also interviewed and questioned a lot of people who are working in this field, experts, but also companies. There is a long range of challenges. And these, again, we have tried to divide into three main groups. There's a lot of technical challenges. There's a lot of the challenges around the development, the resourcing, what methodologies to use, how to collaborate, which partners do you need in collaboration, and of course, questions in the deployment, acceptability, all kinds of ethical issues, and the value proposition. So this is our general overview of what we found in the literature and talking with experts and people who have experience with these applications. So as I already said, many challenges. Most applications get stuck in this complexity and don't go further than a single project. We feel that looking at these challenges can only be tackled with a multidisciplinary approach and in close collaboration of all relevant stakeholders. So somehow we have to find a way to learn together and to fail together, to get better and then win together. The reality in the field is not yet there. The three examples that you will hear of today in more detail will show you some of these challenges in more detail. But first, Stephen Potter will now give you an overview of the projects that we have done. May I ask you, Stephen, to take over?
Yep. Thanks, Luc. That was a very comprehensive introduction, I think, an overview of the field. And what I'll go on to do now is to talk about the specific projects and specific activities that we've sponsored within Pitch-In. But you'll hear many of the same themes echoed throughout this, throughout my presentation, I think throughout today's event. I should just say, to introduce myself, I'm Stephen Potter. I'm a researcher in healthcare technologies at the University of Sheffield. But I've also been helping to manage the health and wellbeing theme for the Pitch-In program. And overall, we've sponsored around 12 mini projects, I think it is now, and one regional engagement project. So some of the other themes, for example, smart cities and manufacturing, have also sponsored health-related mini projects. And there's also been some student internships that have looked at some of these questions as well. So there's been quite a lot of activity. And you can see that we've addressed quite a wide range of different health conditions and different care concepts as well. So sort of conditions that we've been looking at include sleep disorder analysis, point of care biomarker analysis, vital sign monitoring. And the concepts include things like social prescribing, hospital patient flow analyses, and things like this. And also you'll get some idea that this work is taking place in a range of contexts, so hospitals, clinics, homes, schools, but also looking further afield into low resource countries and outdoor and social spaces. In a very general sense, I think our development projects have tended towards earlier stage tasks. So the sort of tasks that involve domain scoping, ideation, co-creation of potential solutions, work looking at the acceptance of technologies. And alongside this, we've also sponsored a few more strategic projects that are focused on aspects of knowledge exchange, such as fact-finding consultations, raising awareness, creating and delivering training materials. And some are also on methodological aspects. How do we go about co-designing solutions? What are the appropriate models for adopting IoT-based solutions into care systems? Just to say something about the nature of these projects, all of the projects involve some sort of collaboration with a view to knowledge exchange. That's basically the guiding principle of pitch-in. One of the things that's worth noting in this area is the very wide range of permutations of partners. So in the projects, we can see that in addition to academics, we've got hospitals, charities, professional bodies, as well as technology companies involved. And the teams themselves tend to be very multidisciplinary. So we did some work just polling the various projects, and we could see that there are various stripes of academics, healthcare academics, more technical academics, public-facing healthcare professionals, but also healthcare managers and administrators and commissioners. And then there's the commercial technical specialists, digital designers, programmers, and of course, patients and public are a key part of many of our collaborations. And just as an aside there, as I was putting this together, I was wondering whether the widespread of expertise is a strength or a weakness, or simply a reflection of the complexity of this field. I mean, are we still waiting for a class of professional IoT for care developers to emerge, or are our projects always condemned, in the best sense, to be multidisciplinary at this level? On the other hand, I would say that there's been relatively little involvement of commercial technology providers, perhaps a little less than we imagined at the outset. I think we have some theories about why this might be so, that perhaps we can return to later. And also there's been relatively little focus on the sort of the later stage questions around developing the business case and developing the business itself as well, and thinking about routes to market. Again, suggesting that maybe this field is still emerging. It's still maturing. So just to give it a few examples, Luc mentioned the three general areas that we identified. So personalized care, which really focus on the health and well-being of individuals. So we've got we've looked at smart care homes for the elderly, sleep disorder diagnosis, self-care of mental health, just to give some examples. In the public health sphere, where we're looking at the health of communities or their environments, we've got work around social prescriptions and childhood obesity reduction. And in the area of smart logistics, where we're looking at how we increase the efficiency of the care services, we've got work that's been looking at monitoring hospital patient flows and resource usage within clinics. I just put this up quickly to show that to give some idea of the barriers that the teams that are working on these projects considered as being the most significant to developing their work. So we did a quick poll, and we found something that's quite surprising, that the most significant barrier appears to be this question of interoperability, by which we mean not just technical interoperability, sort of data sharing and systems communicating, control structures or whatever, but also the idea of social interoperability. How do you incorporate this technology into the existing systems of care? How do you make sure that people are familiar with the technology and can operate safely with and around it? And we also asked the same question about what people think are the downstream barriers. And again, interoperability rates high, but you'll also notice that now, as might be expected, questions about business case, the safety, regulatory, and financial issues start to become more prominent. So if I can quickly try to summarize some of the lessons we've learned across all the projects, and this really is still a work in progress, because we're still gathering the information from the projects, and indeed not all of them are quite finished yet. And so some of these things I think will already be quite well known to anyone who's working in this area. The first is the importance of collaboration. That initial phase of identifying and engaging with stakeholders is crucial. The second is the idea of knowledge exchange, and also the very clear recognition that this is a two-way process. It's not just about academia telling the rest of the world how to do things. We really need to understand the abilities and needs of prospective end users. Also need to understand the structure of care systems, including the various decision-making paths. And we need help, basically, to handle data, to integrate with systems, both technical systems and more social systems. And in terms of development, we could say that there does seem to be a general lack of methodologies and a lack of experience reports, which in turn makes it difficult to communicate best practice. And alongside that, we also see the need to amalgamate practice from several traditions. So by way of an example, this idea of building to collect evidence that's emerging from healthcare, alongside the idea of secure by design that's coming out of software engineering. We need to put these two things together and make sure that they're both represented in our processes. Again, this is something that's probably quite obvious to a lot of people here today. Mixed methods approaches are still necessary. The IoT will give you digital data almost by default, but you still need to do that qualitative data collection in order to understand accessibility, in order to properly assess outcomes and so on. And we're also lacking, I think, the sort of template protocols and agreements that allow us to basically streamline a lot of our processes, such as gaining ethical approval for trials and data sharing, and also the idea of the proper approach to designing and reporting trials. And just a quick link there to the Pitch-In resources site. And again, this is a work in progress, but we're starting to collect some of the resources that are emerging from the various projects and making them available to the wider community. So if you go to that website, you'll see some of our training videos are now up there, and some of our awareness raising tools. And if you check back over the next months, more and more will be coming live on that stream. Okay, so that was a whistle-stop tour of what's been happening in the health and wellbeing theme for Pitch-In. And now I'd like to begin a little showcase of 4 of our projects, just to give you a more of an in-depth feel of the actual activities that have been going on. And the first one that we'll be talking about is IoT-enabled social prescribing at Blenheim Palace. If I can hand over to Anant, and I will. Okay, Anant, you should have control.
Let's try. Okay, perfect. Yeah, perfect. Hi, everyone. My name is Anant. I'm a researcher based at the University of Oxford. And it's been, I think I've been working on pitch-in related projects for probably a good 2 years now. And, you know, I really see the benefits and the potential of IoT. Obviously, as both Luke and Stephen have mentioned, there are downsides and potential unintended consequences. But I think by and large, if we design these applications properly, I think they can add a lot of value and deliver a lot of value to healthcare systems. So what I'm going to talk to you today about is about one of the projects that we have ongoing currently, which is using IoT-enabled social prescribing at Blenheim Palace. I seem to have lost control. Okay, cool. So the challenge, a large proportion of diseases, chronic diseases are preventable and can be brought into remission by lifestyle interventions. I see in the chat a lot of people talking about Garmin and tracking steps and using Strava, et cetera, So I think you guys are all familiar with the power of IoT and actually being able to monitor and track some of these physical activity metrics. Now, obviously, social prescribing is very broad. It also covers, you know, things focused on social determinants of health as well. So looking at benefit support, support with housing, et cetera. But when we look at some of the burden of disease within the English NHS or many healthcare systems in the global north generally, a lot of them are due to non-communicable diseases that stem from lifestyle and behaviors of individuals, whether that be sedentary lifestyles, not eating healthy diets, smoking, drinking, et cetera. And one of the big difficulties with social prescribing generally, because the interventions are so varied, is actually capturing outcomes on social prescriptions. Because the deliverers of social prescribing interventions are typically not within health and care services. They are oftentimes voluntary and charity social enterprise organizations, and they will not have a direct link in. And so it isn't always possible to actually understand what benefits they're delivering. And we did an IoT project. It was the first one that I worked on with Luke and Stephen back in 2019-20 to explore the opportunities that IoT could provide for social prescribing. And there were 3 key barriers that we found within that project: educational, so basic lack of familiarity with the technology; connectivity, so lack of knowledge of the various stakeholder skills and interests and ability to actually connect into healthcare systems. And then there's a business case, which I think Luke also touched on, which is you know, how can IoT actually deliver value or demonstrate value for a given intervention? So I can't seem to control it. Okay, so the project that we did, the University of Oxford, taking the insights from our social prescribing IoT project, which you can see on the website, we then designed a project with partners from Blenheim Palace Aspire, which is a local Oxfordshire charity, which empowers individuals facing homelessness, poverty, and unemployment, and the Eden Project. And we chose Blenheim Palace because they are trying to kind of revamp their role within the community. And they want to be seen as an integral component of the community rather than an us and them type of approach. Aspire for obvious reasons, in the sense that they actually have the beneficiaries that could benefit from these sorts of social prescriptions. And Eden Project, because for the past almost decade, they've been actually running a very substantial social prescribing initiatives within the Eden Project, supporting people with type 2 diabetes to get more physically active, supporting older folks to join in on activities, whether that be gardening or just walks to reduce their social isolation and also to get them moving again. So with this group, next slide, thanks. We designed and ran are running a feasibility study, which is going to go across 6 weeks. Last week was the first start date and will go until the beginning of June, where 10 participants from Aspire with a variety of issues ranging from homelessness, substance misuse, joblessness, will go on weekly walks from 10 a.m. to 12 p.m. at Blenheim Palace. We've mapped out different routes, and on those routes, we also have other IoT sensors integrated. So for example, looking at light levels, noise levels, air quality, as well as temperature and sort of just general, barometric pressure, et cetera, et cetera. We don't expect that information is actually going to have that much of an impact on the experience of the individuals, but what we want to try to demonstrate within this feasibility study is actually capturing that information. And then in addition to that, as I think Luc also mentioned, we have given each individual a Fitbit, so we can capture their physical activity information across the 6-week period. So we actually took 1 week of baseline information where we gave them the Fitbits, and they have been wearing them for 24 hours a day, 7 days a week. And we have their baseline information, and then we're going to collect that information for the full 6-week period of the intervention. And then we're going to continue collecting that data for 2 weeks, 2 to 3 weeks post-intervention. And that will give us some information about, whether their activity levels went up or down, whether it's affected their sleep. And then we're supplementing that with qualitative info that we're capturing through structured interviews, as well as using something called the ONS-4 well-being measure, which is just a set of 4 simple questions that measures an individual's well-being. So we want to see if that increases or decreases over time. Next slide, please. Results, the study's ongoing, so we don't have the results yet, but next slide. What we found so far from an educational and connectivity barrier perspective, so these are things that we identified in our first project, we engaged with the Aspire staff very early on to understand what would work best for the Aspire beneficiaries. So that co-design element was, I think, essential in ensuring that people felt comfortable with this technology and actually engaging in this project as well. And we've also worked closely with the Aspire staff to train them on the use of the technology and also the data platform that we've created to actually capture some of the information from the Fitbits. In terms of the business case, we work with the Aspire beneficiaries firstly to define the outcomes of interest for them, as well as the beneficiaries. What are the things that matter most to them? And then, we work backwards to actually explore the tech options. And we decided that the activity trackers were ideal. And we, I think, did a survey and analysis, probably like 6 or 7 activity trackers. And we decided on the Fitbit because of robustness, ease of use, and the ability to remotely monitor activity levels, which we're doing via a platform called Fitabase, which some of you may be familiar with. Next slide. So in terms of the next steps, obviously we're going to finish this study, the feasibility study. We'd like to then expand it to a pilot to get more people involved. And Blenheim itself, their goal is to become a trusted source of social prescribing within Oxfordshire. They have about 1,000 acres of green space, which could be hugely beneficial. They would like to expand their walking for well-being walks. They want to pilot other social prescriptions as well, and they're keen to understand outcomes delivers. So the IoT element is actually quite essential for this project. So that's all from my side. Just a quick note that I have to leave in 15 minutes, but if you have questions, please feel free to put them in the chat. I'll put my email address in the chat as well, so you guys can get in touch with me. And thank you.
Kat, can I ask you to take over now?
I can. Sorry, I thought we were having questions. Oh,
I can take questions if folks have questions.
My whole screen's gone crazy. Hang on. I can just start, yeah, but I thought that we were having questions after each thing. No, no.
No, we would have the questions at the end of the 3 presentations.
Oh, that's okay. But Anant's leaving soon, so.
Yeah, unless there is a very urgent question to Anant specifically, that would be, of course. Let's do that first. Sorry.
That makes sense.
Anant, there is one question. You can see it.
Yeah, it might be worth saying. Okay, so let's see. Sophia, collaboration key, knowledge.
It's Luis Patino.
Yeah, okay. And then Andy, might be worth saying also our CGP links and work. So the other big thing that I'm involved in currently is working, it's an NHS England Commission project working with the Royal College of General Practitioners to monitor social prescribing uptake and use across England. I'll just put a link in the chat to that so you folks, if you're interested in social prescribing, can take a look at this. This is an ongoing project and we continue to work and build resources for that. The other thing that we have built linked to this is a open crowdsourced platform called prescribing.social, where we have currently a list of about 71,000 charities across England. And it's crowdsourced in the sense that if we've missed something, individuals can input their data and then it will go onto the database. It has an open API and you can download the full data set as well. So it's open, crowdsourced, free to use. And then let's see, I would like to know how social. So social prescribing, according to the NHS England definition, is something that is provided by a link worker to meet non-medical needs of individuals. And that can range from all sorts of things like the lifestyle conditions that I've mentioned here, but it could also be benefit support, housing support, et cetera, et cetera. And in the NHS England definition, it is delivered through a consultation with what's called a link worker. A broader definition of social prescribing is basically a means of addressing non-medical needs of individuals. So in some cases that will be via a link worker. In some cases that might be via practice nurse. It could be via local authorities, local governments, county councils. Individuals can self-refer or seek out help with voluntary sector organizations as well. So the models vary, but that's the bottom line is basically addressing non-medical needs. Is there scope for other commercial partners to get involved in ongoing projects? Is that, Darren, is that question for me or is that generally for the pitch-in initiative? Okay, so maybe, anyways, so maybe Darren, you can put it in the chat. Are there any other questions? I have some messages as well, which I will respond to via the chat.
Well,
Both Anant, I was involved in putting together some of the early social prescribing pilot sites for CCC's in London. Okay, great, Darren. That would be super. I put my email address in the chat. Please do feel free to get in touch with me. And I will put another link in the chat to the NHS England page for social prescribing. Becky, have you had feedback from commissioners of social prescribing with the kind of outcomes you are generating? Well, this is too early at this stage in terms of this project because it's basically just a feasibility study. We only have 10 people. We have to look to scale this, and then that is the plan. Becky's here, spot on there in terms of getting in touch with commissioners to see how this could actually help them to commission social prescribing pathways that are enabled or supplemented with IoT to capture some of that outcome information. The links between IoT captured information and integration into EHRs is something that we haven't even explored yet because it's quite complex, but we want to just take things one step at a time.
Okay, I think we now have to continue with Kat's presentation. Thank you very much, Anant. If there are more questions later on, we will pass them on. Okay, Kat, are you ready to take over now?
I think so. Let me just see if I can control things. Okay, my Oh, hang on. Yes, I can. Thank you. So I'll just start then. It's really nice to see people's faces. Thank you for the people that have put their cameras on. It makes it a lot more interactive. Thank you, Richard, Darren, Kim, Stephen, Luke, Anant, Pam. Thank you, Pam. Who's that? Louis? You can say anything. Belinda, thank you, dude. Catherine, Gail, Stephen, take this off my time. This is called rapport. Sophia, David. No, click down. No one else wants to. It's nice to see you all. Thank you. And lovely to be here. Thank you for inviting me. So I'm going to talk about a project that Pitchin funded on identifying challenges and barriers to using Internet of Things in mental health. I am not a techie. I am not a computer science girl. I am very much on the human side of things. And I absolutely love collaborating with my ComSci buddies on all of these projects that we run, because I think we bring that interdisciplinary mix there. So on this project, it says Dr. Kat Easton, but on my slides, I actually had a list of people that included Dr. Claire Bentley at the University of Sheffield, Professor Belinda Lennox at the University of Oxford, and Miss Chrissy Bonham, who is a key collaborator in this project. She ran our workshops for us, so I don't know why they aren't there. Stephen Potter, you're in trouble. Move along. No. Okay, the challenge. If anyone knows anything about mental health, we know that supply of kind of traditionally delivered mental health services can't meet demand. It just can't. Digital technology might offer a solution, so we could increase access, availability, or give people more choice over the way they're supported to promote positive mental health. But research suggests, this Hollis 2018 James Lind Alliance project that I was on, published in the Lancet Psychiatry, says there's a really lack of knowledge from the public and practitioners, but a lack of trust in any digital tech. People are scared. There's a lot of fear, lack of understanding from the public, and that makes it really hard for companies to come into this space and talk to people about this and engage them with this. So that's the big challenge, really. Why can't I do this? So we got funded by Pitchin, thank you very much, to run a project to look at the barriers around lack of trust with key stakeholders in Internet of Things, in mental health then, but with serious mental health. So people that are struggling in recovery and maybe have been recently discharged from hospital in the community and are trying to find their way now functionally in life. We wanted to involve patients and carers in talking about digital tech. And this project then really, bearing in mind like the Pitchin aims, addresses the problem of interaction between specialists in terms of the tech specialists and then people with lived experience, talking to them about their issues and what matters to them. So the goals were to identify challenges, first of all, that people faced when they were recovering and setting their goals for life. Look at what exists already in terms of technology and how that could be applied in their lives, and then identify some of the barriers and facilitators that could be there to support different interventions for people. So what we did was, myself and Chrissy Bonham, we ran it. Chrissy Bonham is a narrative storyteller. So we decided to do some really nice workshops, storytelling workshops with people. We ran 3 of these, and we held them at a really central location in Sheffield, a place called Blenheim Kitchen, which was a kind of service user-led cafe where people could come and feel really safe. 12 people came to all 3 workshops. We provided refreshment, really nice treats, and paid people for their time and their input in the project. And we created some storyboards and an animation. So can I zoom in on this, Stephen? How do I? So on Blackboard, I can zoom in. No, I can't. Let me see. There we are. Stephen, can I zoom in on this storyboard?
No, I don't think so, Kat.
Okay. Well, I know it inside and out, so I'll just tell you what it shows, but I wish I could zoom in. So this storyboard is one of about 7 storyboards that were created from the whole project. And we had storyboards on challenges. We had younger men talk about their struggle with alcohol. We had people talk about the issues they faced with money management, and just managing the house as well, like housework and cleaning up and that kind of thing. And this image here, you can't see as well, but I hope we can share it soon, shows some of the barriers as well to why people might not want to engage with IoT. So we've got issues here around the fact that people have to go to the library to get Wi-Fi and use the internet, and they don't really want to go to the, well, they don't want to go to the library first of all when they're feeling really unwell, but who wants to sit in a library and then have everyone around them see what's going on their screen? People are scared about the fact that all their face-to-face care might be taken away. Issues with digital literacy, which we know about anyway, the cost of all of the products, and there's a real fear as well about, it's the bottom second from the left, you can see this image where people are scared about who, like, using technology and then who can see what I'm thinking. It's this massive fear that sometimes we all have as well about what a company's looking at and what can they see, and can they tap into what I'm searching, and data privacy and all these fears. So there were some real fears there from people, and that's massive because how do I scroll? It's not doing it. Okay, sorry. And that's a big deal because unless we get buy-in from some end users with mental health issues that will ultimately be using some of these products that we come up with, we've got no chance. So co-production is key. We need trust and solutions that people actually want. There's a link here to a YouTube animation. I don't know if we've got time to show it, but I'd love it if we could.
Well, now you cannot. Sorry.
We've not got time.
No, but you can put up the link if you want in the chat.
Okay. Well, the link is there, and people can find it. I think Stephen will probably share it. The next steps. So we've done a series of webinars that are again available for everyone to watch. Pitching kindly funded these, and they were in collaboration with Mindwave Ventures, where we looked at issues around co-design, industry and academic collaborations, evaluation of tech, and then how we can implement that in the best way. We had some amazing experts on board with that. We ran a hackathon at the end of that, where we came up with 2 solid ideas to move forward. And now we want to obviously push them forward for, you know, a national grant application. Can I? Sorry. Thank you. But you should check out the animation because it's pretty top.
Well, that's great. I have seen the animation and I can indeed tell you it's worth looking at. Absolutely. Thank you very much, Kat, for this overview. Time is running fast, so I think we have to go immediately to our next presenter, Professor Belinda Lennox. And at the end, I hope we still have a few minutes time for questions. So if you have questions, please use the chat. And if we don't have the time at the end, we will find another way to respond.
Thank you, Luke. Hi, everyone. I'm Belinda Lennox. I'm a psychiatrist. I'm a clinical academic psychiatrist in Oxford, and I'm going to tell you about our project, which is also in mental health. And it's a very sort of a focused project, I guess, improving personal care of individuals with serious mental illness using point-of-care testing devices. There we go. Okay, so the challenge that my project was trying to address was the particular problem of poor physical health outcomes in people with serious mental illness. And serious mental illness, I mean things like illnesses like schizophrenia and bipolar disorder. And actually the physical health consequences, your risk of early death, I mean, it's a really shocking statistic that you die 15 to 20 years earlier than someone without those diagnoses if you have a serious mental illness. And the cause of death are largely cardiometabolic illnesses, stroke, heart disease, also lung cancer. And you'll see the risk of death by age group if you have a serious mental illness and compared to the general population. And, you know, it's people in their 40s and 50s that are dying with these disorders. It's really, I mean, it's really a sort of a public health emergency. I would put it as strongly as that. These are relatively common disorders, and we're really, you know, not treating people well at the moment. And the reasons for these increased rate of these disorders is a whole range of factors, largely lifestyle factors, a hugely increased rate of obesity, of diabetes, for instance, but it's also access to healthcare. So, you know, there's well documented inequalities of people with a diagnosis of schizophrenia presenting with chest pain being less likely to get investigated and treated for that presentation, you know. So there's this sort of what we call sort of diagnostic overshadowing that goes on. People don't get an, you know, an equal provision of healthcare. So for that reason, it's an NHS, it's a nice recommendation, and it's an NHS mandated measure that everybody with serious mental illness should receive a physical health check every year, and it's looking for you know, things like diabetes, and it's weighing people, and it's looking at your blood pressure, and you should be offered the appropriate interventions if abnormalities are found. And this shows the annual audit of over 10,000 people last year, and each of those bars is a team across England to show how well they're doing in actually doing these physical health checks, and showing that, you know, there's a huge variation across teams, but a lot of teams do very poorly, you know, down to a few % of people on their caseload receiving these physical health checks and getting the appropriate interventions. So, you know, it's the job of mental health services to make this happen, but we're okay at providing the mental health bit, but we're pretty poor at providing the physical health bit. And trying to unpick why that might be the case, we did a bit of process mapping of what happens in our team, which is an early psychosis team. So we follow people up intensively in the community from a mental health point of view, and we identify people as requiring a physical health check. And actually, it's quite a convoluted process to get that done. You may have a clinician, a care coordinator, who can take the blood tests required as part of the physical health check, and that they would do that for, at the patient's side. But then they send those blood tests off, and then they get lost in the bowels of the general hospital where the tests are done, and they don't get automatically fed through to the mental health trust. They get printed and sent on a bit of paper, so they arrive, a few days, stroke several weeks later in an admin inbox, and then they have to be checked by the doctor and the results uploaded into the care record system. And so you see the feedback loop to actually tell the patient what their results were and actually do something about it if it happens to be abnormal it's a broken system. If you don't have a care coordinator that does the blood tests, you actually give out a bit of paper to the patient and ask them to make an appointment at the GP to get it done. And then all sorts of reasons why that doesn't happen. I mean, it takes quite a motivated person to get into a GP surgery. And then again, the blood tests are done then, and again, the blood test results don't get fed back. So that's the sort of existing situation and the problem we were trying to address. So our solution that we tried to try and improve this situation was a point of care testing device. Now we reviewed all the point of care testing devices that did the 2 blood tests that are needed, which is an HbA1c as a blood sugar measure and a lipids measure, so cholesterol and other lipids in the blood. And this was the best device that did both tests and did it in a reliable way. And that was really important. We actually found a bit of kit that did what it was meant to. In a reliable way, and it's produced by Abbott. It's called the Affinion 2, and it's a portable device, so you can take it to the patient's side, and you take a pinprick of blood, you put it into a cartridge and put it into the machine, and then a few minutes later you get the results. So whilst you're there with the patient, you can tell them what their cholesterol is, and if it's high, you can get a plan together about what you're going to do to improve the situation, and you can have that discussion there and then. The results feed through Wi-Fi connection into the General Hospital biochemistry department, where there's a level of quality control that goes on the blood test results. And then an important part of our project was also to integrate the data between the machine, the General Hospital and the Mental Health Trust records, so that the results, as well as being immediately available, would get fed straight onto electronic patient records for the patient. So these were our partners, and it was a range of healthcare folk, of data integration IT folk, and crucially, a guy who now works for Acrivia Health, which is a sort of a mental health informatics company, but he was a sort of chief information officer for a large mental health trust, and he understands the language both of mental health and of data integration, and he was a sort of key person with all of this linking up that we tried to do. We also had the crucial collaboration of people with the NIHR MIC, with the very long name at the bottom there, but basically they're an NIHR funded collaboration who are tasked with evaluating healthcare technology devices, and they provided the quantitative and qualitative evaluative expertise basically for testing, whether this bit of kit worked or not. And that was a sort of crucial collaboration really across academia and health. And these were our results. So what we did is we introduced the machines over a 6-month period, which is, it's very small writing, but it's those last 2 time points basically. And we introduced into one team in Oxfordshire, which is the red line, and we also measured the recording of physical health checks in a parallel service in Buckinghamshire, and that was in the black line. And on the left-hand side, that was the rate of the blood test completion. So those are the particular blood tests using the point-of-care testing devices to show an increased rate in getting those done, a quite steep increase. Up to 40% of the caseload were tested in a 6-month period. But also on the right, importantly, the completion of the complete physical health check. So all of the other measures were more likely to be done as well, because in the couple of minutes you're waiting for your blood test result, you can do the blood pressure and you can do someone's weight and you can have the discussion about smoking cessation and so on. So actually, you know, it had a dramatic improvement on the whole of the physical health check. But really crucially, we also did semi-structured interviews with the staff and the patients when we used this device to see, you know, how was it for you? And the service users universally found it a positive experience. It was easier, quicker, less painful. They talked about getting really worked up and anxious going to a GP surgery for a blood test. And they found the lifestyle discussion actually, you know, really helpful, having someone face-to-face to discuss what it meant rather than just perhaps being texted your, you know, your cholesterol level. And the staff that used it in the clinical service also found it, you know, the machine itself was usable and, you know, portable, was no problem, and it increased engagement. And actually they really liked the combination of being able to do the physical and mental health bit all in one parcel. I like that quote. It shouldn't be physical and mental health, it should be person-centered. So I suppose the lessons I've learned from the project are, it was vital to get the qualitative aspects, the experience bits, to understand the barriers, because as well as the team that successfully used the device, we also tried to introduce it into other mental health teams where it did just sit on a shelf and they didn't do it. So it was really useful to understand why that was, and it was due to their sort of culture and training and expectation. There's something about an early psychosis team that really sort of grabbed the opportunity, whereas other mental health teams just didn't think it was part of their job. But it wasn't anything to do with the kit itself. It was all to do with the human factors. And I suppose, you know, the other key learning factor was really that these boundary spanning rare individuals that can speak the different languages of the different sectors are absolutely vital to connect systems together. And where are we going next? Well, it's exciting times. Actually, this body NHSX, which is the sort of digital technology bit of the NHS that's been put together, has the delivery of physical health checks for people with SMI as one of their 3 priorities for this coming year. So they're throwing quite a lot of money at regional teams to deliver these interventions. So they're all coming and asking us how we did it and how they can roll it out as well. We've been funded by NHS England to broaden our evaluation across the whole of the southeast of England with the lovely logo there for the Carmen 2 project. And we're also looking at other devices as well, and particularly evaluating, this is a handheld ECG monitor, the Alive Core, which provides a measure of a QT measurement in an ECG, which is really important for prescribing of medication in mental health, for instance. So I suppose this is just as a thank you, I wanted to thank Pitchin really for making this happen, because actually I think the greatest contribution was the integration of the data across systems. And it sounds a bit boring and it sounds a bit small, but really it's a game changer for people using these devices. You know, that actually you don't have to fill in bits of paper and you don't have to do things multiple times. And that really would not have happened without Pitchin. So thank you.
Well, thank you. I think this is a beautiful example of what can be done if you do it right. So thanks a lot. We are getting into a little bit of time pressure, so I would like to ask Stephen to take over immediately, and then hopefully we have some time left for questions and some concluding remarks.
Okay, thanks, Luc, and thanks, Belinda. That was a great presentation and a good example of how we can start to build the evidence and really use IoT correctly. And just as something of a contrast, we wanted to finish the showcase with a project where things didn't quite go according to plan. Where picking up on the idea that Luc presented right at the start of learning how to fail better. Well, here's a project that didn't quite achieve all that it set out to do. I'll try to explain why. The challenge in this case was about connected care homes. So there's been a number of systems that have been proposed. Some have even reached market for IoT-based domestic behavior monitoring. And typically these are focused on care of frail elderly, but also people with cognitive or physical disabilities. But despite systems being available, these have failed to make a real impression on care provision in the UK. And so the challenge here, we think, is to bring together all the stakeholders to demonstrate the technology, but also to critique it and help to develop and help to perhaps adopt technologies where they are appropriate. And in this case, the stakeholders, councils, housing providers, care professionals, care service commissioners, anyone really, and everyone. Which just it kind of demonstrates really how this sort of technology can really touch many different services and many different individuals in different ways. So the idea we had was to develop alongside the stakeholders community located connected care home demonstration facilities, and we had two particular plans. One was to retrofit existing residential council-owned property with the technology. And the other was to design into the infrastructure of a new build in a healthy aging show village. So we had these two ideas of how do you use legacy housing stock, and how do you get these ideas into new stock. And then once these facilities were up and running, we'd then develop and run a series of encounter events to encourage knowledge exchange between various stakeholder groups. So it could be between technology providers and end users, or housing providers and family members, and healthcare professionals and technology. So you can see the different combinations bringing people together. And possibly also run some longitudinal trials where people live with the technology over an extended period and really road test it. And the aim was to have sufficient buy-in that the facilities would be self-sustaining within a relatively short period of time. And for partners, we had the Centre for Assistive Technology and Connected Healthcare here in Sheffield, and also the National Innovation Centre for Ageing in Newcastle, plus local councils, housing developers, tech providers. But things didn't go quite to plan. When we actually got the project up and running, council involvement sort of evaporated, and I really don't want to blame the council too much. There's a lot of high internal staff churn, but there's also unclear decision-making pathways and little freedom and few incentives, I think, for innovation. And as might well have been predicted, the new build development was delayed and is still delayed as far as I know. And this, of course, is subject to all sorts of extraneous forces, most of which are out of our control entirely. So what did we do? Well, we scaled back our aims quite considerably, and we developed, along with some of our best and bright students, a working scale model of a connected care home. And we'd begun to demonstrate this to the local council and also at an assistive technology conference. But then COVID-19, and that effectively curtailed any plans that we had to exploit the resource. So what were the lessons? Well, I think from our part, we were probably quite naive about the involvement of the stakeholders. We probably needed to do more work in advance to build the collaboration, maybe even leading to formal commitments from partners. We probably needed to do more work identifying who were the key decision makers in potential partners. And I think also our business plan was probably a bit naive too, and we needed a clearer business plan, and the sort of in-kind match funding model probably doesn't work for the partners we had in mind. And added to that, I think we were probably over ambitious. But overall, it emphasizes the importance of building and maintaining collaborations in this sector, because without collaborations, you're never going to make any sort of real impact. And so in terms of next steps, we think the potential remains for IoT-based domestic care monitoring. The challenge still remains, though, of understanding and finding the most acceptable and effective ways to exploit the technology. And we still think that there's a need to bring together the stakeholders in this space to help co-design and de-risk development and adoption choices. And it's really just finding the correct vehicles for doing that, which is still something of an open question, and probably goes beyond pitch in to think about the sort of provision of facilities and expertise to support the digital health sector more generally in the UK. Okay, thank you. And because we're a bit short on time, I will pass directly back to Luc now to provide a summary. And I'm happy to answer any questions in the chat.
Well, thanks. This was indeed an example of a project that didn't really work according to the plan, but we learned a lot from it. Before coming to a kind of end, I would like to invite you to look at the questions in the chat. I see that quite a few have already been answered by direct interactions, but let's have a look whether there is some specific things left. I assume that you all had a look already. Kat, were there any questions for you that you have seen and not been able to answer?
I'm just scrolling through now. I don't think so, because I think the ones I've seen now are for Belinda. But I might be wrong. If I haven't answered a question, I'm happy to.
Okay, and Belinda, did you see some questions that you have not responded? I saw you are very active and immediately.
I think I've answered everything. I'm trying hard. I'm very bad at multitasking.
Yeah.
There's a lot going on there.
Yeah, of course.
But people can just shout out as well if they've got a question.
Well, there's one very recent question for Stephen about the accuracy of currently available home-based IoT systems.
I mean, thanks for the question, Lewis. I think that's a really fascinating question. I mean, it raises the question what these systems are actually measuring, and I think it gets to the heart of really why there are concerns about the accuracy, because what these systems tend to do are measure circumstantial facts, if I can put it that way, or social facts about people's behavior. And from that, try to infer whether or not there's a problem, or whether or not there should be some sort of intervention. And I think that's exactly where the problems arise with a lot of these systems. That there's quite a high tendency to introduce false positives, to raise alerts and flags when something looks unusual, but can be quite easily explained by someone leaving the door open by mistake, for example. So I think this is perhaps the area where maybe more work is needed around sort of AI and machine learning, just to tweak the systems. But also I think more work is needed to understand how to integrate these systems into the existing care and emergency networks that we have. And that I think is one of the principal reasons why these systems haven't been so successful as you might expect so far.
Yeah, you're right. It's a very complicated issue, and there's a kind of layered problem as well, because you have the accuracy of the initial measurements, and then the accuracy of the integration and the interpretation, and the accuracy of any actions that follows on. So, but it is something that needs much more attention and research, for sure. There is some, well, we have 5 minutes left, so I will have to come to kind of conclusion, but there's a kind of concluding question or suggestion from Mark Hawley and a question from John Clark to all of us. Mark says, is it possible for Pitch-in to develop into a national infrastructure and support for the development of this area? I think personally that it is a very important suggestion. And when I look at all these examples and what we have learned, is that my main conclusion is that it is an extremely complex field that really requires multidisciplinary efforts from very different stakeholders. And I think personally that you cannot do that on a project level. So I would think it would really require a kind of national strong program, a national center or a national program really to tackle these things. But that's my personal opinion. So maybe the other speakers can reflect on that a little bit. But also then take the question of John Clark, what is the main challenge to how you will play a role in innovation? Or what's the main change to how you will play a role in innovation as a result of the project? May I invite the three speakers still present to respond, to reflect on these two issues? So
I can go.
Yeah, please do.
I'm not going to change anything. What we do in our research and the way we co-produce solutions is working, and we're doing very well with grant capture. We are doing well with how we make a difference. So I'm not going to change anything.
Well, that's brilliant.
Because I think what the Pitch-in funding gave us the opportunity to do was show other people how co-production is really necessary. Yeah. Not just with people with lived experience, but with so the health professionals, and then the people that design and build the tech. We need to be more collaborative, and we can't have egos. And it just bores me when we do.
Okay, so, good. That's a clear question. That's a very clear response. Thanks. Belinda, may I ask you to reflect on these issues?
I don't think I'm going to change anything either. I mean, I suppose I'm excited at the possibilities, and there's just huge opportunity. We need much more. You know, I want to be more of a champion. I want to seen as more open to to companies with brilliant ideas to co-produce with CAT and roll it out as widely as possible. Absolutely. Let's do more.
Nothing different, just more. Good. That's an. What about Stephen as a very last?
I'll address Mark's question. Perhaps not directly answering it because I'm not sure what the answer is, but just to point out that we did some consultation around an enterprise survey around the companies that were working in this area. And indeed, one of the things that came out of that is that we do need more infrastructure and support for development in this area. That in particular, that there's quite a strong need for test and co-design facilities just to make it available, because a lot of the companies in this area are SMEs and in particular micro enterprises. So that they simply don't have the in-house resources in order to do this. But the expertise is here. It's distributed in particular around the universities. It's just how we make that expertise available. And I think that's a key challenge for the whole sector for the next years.
Well, thanks. Unfortunately, we reached the end of the hour and a half. This is always a problem, but we can't spend all afternoon with headphones on. And I hope this session has given you a flavor of what is possible with IoT, but also what are the challenges. And we have seen some great examples, some less great examples, but I hope anyway it was stimulating, and be sure that we will think of next steps and how thinking about how we can build this infrastructure to really stimulate this field further, because I think it's worth doing that. Just there are a few forthcoming attractions. If you like to hear more about IoT, but then in different sectors, we have a lot in the offering the next few weeks, each week on the same date, same day, same time. Sessions on what was done in the field of energy, the smart cities, and the manufacturing field. And then on 16th of June, there will be another bigger event on innovative practices in IoT conference. It's all listed here. You can, on the website, you can register, you can find more details. So we hope that we will see you, at least few of you, during one of these sessions again. Thanks a lot. The recording will be made available, plus the slides of the presentations, Kat's animation. So if you have more time afterwards, it's always possible to find it and to have a closer look. Thanks a lot. Thanks to Stephen for preparing part of this. Thanks to our support, Elizabeth anyway, and because you have been safeguarding all the technicalities, it all worked fine. So I think we can, I would like to thank you all, and let's hope that we can meet again in some interesting collaboration. So thanks and goodbye.